get excited when I get to give this talk. As Dr. Troxler mentioned, we consider harm reduction to be extremely important to the topic that we cover around MAT for this echo. And I personally feel like it's kind of the underpinning of how we approach MAT and treatment in general. So what I'm going to do is I'm just going to give you sort of a brief treatment about it. Some of you may be familiar, and others, have heard the term and not really sure what it means. But hopefully we'll be able to illuminate some of it. If you have any questions, we can also provide some literature as needed. So I will be covering harm reduction and really sort of how we can prevent overdose mortality through this practice. I have no conflicts of interest. And so here we go. This is what we're going to do today. We're going to quickly go over the trends in overdose. All of you are familiar. There may be one or two things that I'll cover that will be interesting, but then we'll go into risk factors for misuse, abuse, and overdose, put harm reduction in sort of the context of the spectrum of intervention from non-use to overdose, and then incorporating harm reduction into your primary care or addiction medicine practice. So yeah, so as I said, I'm sure all of you are very familiar with what's been going on for the last 3+ decades. What's worth mentioning is that we are seeing a bit of a, as you hear constantly these days, a flattening of the curve with regard to overdoses from opioid pain relievers, and that's the product of some effective prevention methods and good treatment. But really sort of from the prevention side of things, where we've made it more difficult for diversion to occur and misuse on into addiction with these medications, folks who have become sort of, they've become addicted through the use of the prescription medications, have had to move on to the street market and seek out opioids in that way. So our heroin overdoses have spiked in the last 5 to 8 years. And then most recently, we've seen overdoses and mortality from fentanyl adulteration really take off. What's not pictured here, and I think probably the next time I give this lecture, I'll incorporate it, is the sort of concomitant curves we're seeing with regard to methamphetamine use. And anyone who is prescribing opioid treatment medications, are going to encounter that issue and need to be really sort of nimble to address it. So those numbers are not consistent across the country or across the world or within states or counties even. So, one thing that I'm trained in public health. I'm an epidemiologist by training. And so that's the direction I come to harm reduction from. And so anyone in my field, and I would encourage anyone else to look at this map and wonder why we see these differences, across states. And I think all of you could come up with a handful, and if we put it together, we could come up with a giant list of why we think, where you live matters, all the way from poverty up to prescribing rates. What's also sort of playing out here is it's harder to conceive of, but we can see that the drug trafficking routes are also contributing to these differences in overdoses. So just starting with misuse, so I like to sort of go all the way back and then move forward. So starting with misuse into use disorder, sort of some of the risk factors for these things. Poor mental health, physical health, adverse childhood experiences, social support, family history, having access to the substances, and with prescription medications in particular, we saw a lot of lowered perceived risk given that many of them were accessing them through a medical provider. None of these items here are either necessary or sufficient for use disorder, meaning that you don't have to have any of these things, and none of these things on their own would necessarily facilitate an addiction. and this is a very limited list, but again, from a public health standpoint, we look at these and see these as opportunities for intervention. So moving on to overdose risk factors, just going through a list of these. So from the literature, frequent use, high dosing, reduced tolerance. So one of the things that kind of can be surprising to some folks. I'm sure none of you all on the call here, but that reduced tolerance increases risk. So whenever folks get out of jail and then they get out of treatment, a lot of times people go back to the dose that they were at prior to being incarcerated or going into treatment and will overdose. So previous overdose, so sort of that behavioral trend. Using alone, mixing other drugs, your age and your physical health, and then the drug quality. And the drug quality, and I like to, so specifically, I'm interested in, we see a lot of volatility in the drug quality from illicit drugs, given that they're not regulated in any way, and there's a lot of sort of, eye on the ball, as it were, with regard to wholesale drug sellers and street drug sellers that they're not necessarily concerned with their client base, and so they'll do what they need to do to make the money that they're looking to make. And so not only will they look at the different quality, which it's hard to predict for a user to use the same dose and how they're going to sort of dose themselves, but also fentanyl is becoming so prolific. It's essentially being used to mimic any substance that it looks like. So we're seeing it in cocaine, methamphetamine, obviously heroin, and so it's becoming a huge problem. Again, from a public health standpoint, we see these as opportunities for intervention. It's worth mentioning as well too that folks come to this risk legitimately with prescriptions, and so there are some factors just with regard to how we manage those prescriptions, or how clinicians manage those prescriptions, and reduce that risk for overdose. So what is harm reduction? What you see on the screen here is the published definition by the National Harm Reduction Coalition, and those folks are really good at what they do, and I agree wholeheartedly with this definition. But they will tell you, if you speak to a harm reductionist, that it's really about social justice, and the idea, the concept of harm reduction can be applied to any number of health issues, and so we'll lay out kind of the philosophy here, but it's really about, and why I say that it's the underpinning of medically assisted treatment, and how you really want to approach it is because it's sort of about changing your own personal philosophy towards the issue that you're addressing, and I'll explain kind of what that looks like. So some of the strategies that we do sort of employ with harm reduction. First and foremost, we're going to reduce stigma, and that really starts with us, sort of reducing and sort of taking a personal inventory and identifying what our stigmas are towards the population, and really just starting there. And then, some of the services that we promote are increased access to evidence-based treatment. So following the evidence. So that means, medically assisted treatment. The results are in on its effectiveness, and so we support that outside of any kind of moral, perceived moral applications with regard to that. Thinking that we're trading one drug for another is an argument that we hear, but in harm reduction, that argument doesn't hold water, because the evidence shows that we save lives with medically assisted treatment. Increasing access to naloxone, another one of those things that's much less controversial now than it was 6 years ago. Giving folks who have overdose, making sure they do not die from their overdose, no matter what. Teaching safe injection practices and safer use, which can, in the day of age of fentanyl, can reduce overdose and overdose mortality as well. Needle and syringe exchange is extremely important, and for my money, probably the most purely harm reduction service that we see kind of widespread application of today. And considering safer injection site implementation, and I write this sentence. This is such a sort of softball here with regard to this topic because it's extremely controversial and we don't have real good traction in the States now. However, it's being done around the world with proven effectiveness. So I really like to put harm reduction, and I think I've been trying to do that from the beginning of this talk, putting it in context of all of the things we do to try to intervene with regard to opioid addiction, substance use addiction, these things. And so if you go to the left side of your screen, you'll see, non-use. So the individual, who is not, sort of misusing any substance whatsoever, all the way to, that same individual potentially overdosing and dying from use of a medication. And of course, mortality can occur at first misuse, especially again in the age of fentanyl. It's very dangerous, which is why we try really hard to impress that upon our children. I have teenagers, and I drill it into them. But thinking about the progression from non-use to overdose mortality. So primary prevention, we're really trying to keep folks from starting to misuse whatsoever. Just never experimenting, right? Primary prevention, and that usually occurs in our adolescent population because they're at such high risk for impulse control issues. And so then moving into our secondary prevention, we start screening folks. So screening, brief intervention, and referral to treatment expert, which can occur and is designed to occur in primary care practice, sort of a large, really sort of trying to get it to everyone who walks into a doctor's office so that people who may not know that their misuse is actually putting them at risk for an opioid addiction. And through that screening, we can educate people and perhaps catch some of them at that point. And then, our harm reduction is when we start, we have folks who are, sort of in the throes of an addiction, and we have to think of ways to keep them alive and as healthy as possible long enough for them to make it through, what they're going through. Medically assisted treatment is one of those approaches. Drug court is another, where we, rather than incarcerating, we give folks the opportunity to go into treatment and seek counseling and do these things so that they can address their use disorder rather than sort of their criminal activity as much. And then of course on into the application of naloxone once an overdose has occurred to prevent death. Within the clinical setting, there are some things that are effective, and some of it really sort of before we talk about sort of the specific practices that you can get into that you can see here, it really starts with, again, with that destigmatizing attitude for ourselves. And I think this is an easy sell in this population, because physicians, you all are you take the Hippocratic Oath and you're out there to help folks, bottom line. And so just understanding, kind of, educating yourself on what relapse looks like and what, reasonable treatment outcomes look like, and being flexible and dynamic and working with those patients. But yes, screening, so aspirate, as I mentioned, is something that is very effective within the clinical setting. Prescribing buprenorphine is something that we advocate for here in this ECHO, and also co-prescribing naloxone, which doesn't occur as often as you might think, or as we would like. Just really, if you are prescribing an opioid, also co-prescribing naloxone can help reduce overdose mortality. So as I said, the results on medically assisted treatment are in. It is highly effective in saving lives and keeping folks into treatment long term. Naloxone is also very effective at a population level for reducing overdose mortality. Early application of naloxone showed really dramatic reduction in overdose deaths, and it continues to be the case. As I mentioned, syringe programs are currently the most applied pure harm reduction service that we have. The primary goal and sort of usually how these services get funding to start their work is to reduce the incidence of HCV and HIV in the population of folks who are injecting drugs. But given that service, which, you know, I say it's an essential service for that population, you know, if you build it, they will come, which is not necessarily true because it takes a lot of nuance to be able to make that population comfortable enough to come see you and receive those services. But you can, in that delivery of service, you can provide them naloxone. You can provide testing for, you know, infectious diseases. You can give them information about treatment. You can just interact with them and show them respect, which has a huge impact on this population. We hear time and time again from folks who say, you know, that they haven't been looked at or smiled at in a month. And having someone just look at them and ask them how they're doing and give them things that they need, it can be, from a human level, it's very impactful. So key tenets of harm reduction include minimizing harm, ignoring, you know, versus ignoring or condemning. So, you know, it's not about saying, okay, well, you know, those guys are junkies, right? So that's the extreme sort of, in my opinion, case of, you know, they're on their own. Also not, you know, condemning their behavior, you know, but actually getting involved with the population and finding out what it is they need, like meeting them where they are so that we can work with them and just keep folks alive and as healthy as possible. And that's just, I mean, I could just make 2 slides or 1 slide and just say that, you know, harm reduction is about keeping people alive and healthy. We're about functioning and well-being, as I said, versus cessation. So pure harm reduction, you know, while we do have the opportunity and we take those opportunities to you know, increase the likelihood of, you know, treatment admission, it's not really about that. It's just about you know, meeting folks where they are and giving them what they need. And acknowledging a continuum of behavior. So within, say, for example, injection drug use, harm reduction accepts that there is a continuum of behavior within that activity. So a drug user is not a drug user is not a drug user. Someone who is injecting heroin can do it at a lower risk or a higher risk. Back to those sort of list of things that increase risk for overdose, you know, mixing drugs, high dosing, frequent dosing. You know, we see people who are folks who are just trying not to be sick, and so they're maintaining, you know, their tolerance, and other folks who are still chasing that high, and so their tolerance is going up, and those are the folks that are going to more likely wind up encountering fentanyl and overdosing. So that continuum of behavior is very important with regard to harm reduction and how we can affect different things along it. Recognizing the cumulative effect of social determinants, you know, back to the map, you know, understanding the population that we're in, what they need, and how we can address specific social determinants. Neutral on legalization or decriminalization. It's not really, you know, sort of in our wheelhouse. And so this bit here, you know, I get pumped when I get to this part in the slide deck because, again, I'm from public health and we love our theoretical models. You all are probably familiar with this in medicine. I found, I think a lot of folks are, because we, you know, as if we're doing preventive medicine, you know, we encounter this cycle a lot as, you know, folks engage with some new behavior or new behavior change, then they, you know, go to maintain and then relapse and back and forth until, you know, hopefully we reach a point where, you know, it sticks. But, you know, before people come into your office and are receptive to you, you know, working with them on behavior change, they're pre-contemplative. So they're in their behavior and they're not thinking about or interested in change. Now, surely, you know, we know from research and talking to folks who are dealing with addiction that there is a lot of guilt and self-reflection and things that go on and people feel stuck less than just not thinking about changing. But without harm reduction services like syringe programs, we would not be able to encounter this population in that stage of pre-contemplation right? So we only would encounter them if they say go into treatment, are forced into treatment through sort of interaction with law enforcement and these things. And so this is a really incredible opportunity that is provided when we take that perspective of, okay, let's just go where they're at, and then a lot of good things can come from that. So harm reduction in the clinical setting. So how folks can kind of adapt some of this stuff, or perhaps taking this world of harm reduction and applying it, in the clinical setting. It's worth saying, and this is sort of to the left of that diagram towards prevention. Just it all starts less and less so as we, as I said, more people are moving into the illicit drug market, but certainly responsible opioid prescribing principles are important. So seeking out other alternative therapies, starting low, going slow, and so forth. But with all of this happening, it's become difficult for a lot of people who really, really need pain medications to get them. And so, that's a balance, but doing it responsibly, of course, is job one. So pulling from SAMHSA's overdose prevention toolkit, this sort of illuminates some of the ways that harm reduction is sort of embedded in how our federal agencies recommend approaching this stuff. So just learning how to prevent and manage overdose. So what it looks like, what do you do? Ensuring access to treatment, which is what we're working on here, is helping to demystify the application of medically assisted treatment. Ensuring ready access to naloxone, so co-prescribing with any kind of opioid prescription. Encourage the public to call 911. I don't know the state of it. I know Tennessee has a Good Samaritan law. I don't know if all states do, but this is not very commonly understood, even among folks who are using substances, that you can call the police and not be prosecuted for up to a certain amount, or that someone in your circle has overdosed. So it's important that people know that, so spreading that word as well. And encouraging prescribers to use the prescription drug monitoring programs, and that's been very effective. We don't have comprehensive application. Not everybody's using it, but it has been very effective. So ensuring access to treatment for individuals with opioid use disorder, which is the sort of main focus of the ECHO. We know that effective treatment can reduce the risk of overdose. So getting folks on treatment, getting them a medication that helps with their cravings, and whether it's a partial agonist or a full agonist, some of them are getting some effects of the treatment substance in the case of methadone, and others are not, and in the case of naltrexone. And so, just reducing those cravings is harm reduction from the get, right? So they're not out seeking, they're not putting themselves in dangerous situations, they're not potentially exposing themselves to fentanyl. It's just it stops that curve from going up. So these are some of the options here, as I mentioned, and you'll hear about this later in the ECHO and later sessions, but counseling and other supportive services are incredibly important. We do not advocate for straight up medically assisted treatment. If you're able to provide some counseling, or at least work with some of those services that are around you in your community to do that. And you can find information on treatment options for folks in your community through state health agency or SAMHSA. Contact us. There's lots of ways for you to find out what's available and who you can work with, because they will work with you. For sure. I mean, it's referral is the name of the game. So patient-centered care, this is about those sort of reasonable treatment outcomes, trying to offer your patients a menu of what is available to them, and working with them to see what's going to be effective. If you're able to integrate primary and behavioral health care, this is really great. This helps to catch folks and give them that quick sort of opportunity, rather than them having to be referred out if possible. Consider offering medication treatment, providing some counseling, again, flexible treatment goals and desired outcomes. and establishing the collaborative relationships. We can't do this effectively because, you know, patients are going to come in with all these things that we need to work with them on, and we need to have a community of providers that can focus on these different things so that we can help the patient. So, you know, trying to, you know, get your tendrils out into the community and working with other folks that you can work with the patients. And then providing or referring folks to recovery-oriented services, so peer mentoring, group therapy, social services, you know. So, you know, there's a lot of work to be done. Harm reduction is not necessarily the easiest approach, but is necessary for, you know, trying to, like I said, keep folks alive and as healthy as possible in these situations. So our key points, this is our definition for harm reduction. And for our purposes, it's basically these activities and things we do to reduce the negative effects associated with drug use. If we're able to talk with folks about opioid risk, screen, facilitate treatment, we can prevent these adverse outcomes. And specifically the prescribing of buprenorphine, co-prescribing in naloxone can really go a long way. But, you know, bottom line, and this is, you know, where, for me, where it starts and it ends, you know, destigmatizing and, you know, having respectful and appropriate engagement with folks who are using drugs, we create opportunities for intervention where there otherwise would not be any. So that's what I have.